Thank you for that. So this is a little bit different than all the other talks, and instead of being like a technical focus, this is more, I think, organizational or philosophical, if you will. So I've kind of lived the multidisciplinary team in a couple settings. I was the medical director for a disease management program that had contracts actually in HIP in New York City and in San Antonio with Humana and WellMed. And the company was eventually sold for $700 million. I'm still here, so I didn't get $700 million. So I really want to talk a little bit about just who gets to play on the multidisciplinary team, and then I want to talk a little bit about clinical outcomes. So, I mean, what's the opportunity? So maybe this isn't a great example because this is Tantalus, so he never gets the fruit and he never gets a drink of water, but he keeps on reaching. So the lower extremity model is common, it's very costly. There's a lot of recidivism for vascular disease and for wounds and for infections. Many of these are preventable and treatable when they're put in front of the right people at the right time. So the whole idea of kind of this disease management model, if you will, is to screen people early, identify them when they have wounds, identify the people who have vascular disease, refer them early, and make a shift from the hospital side, meeting your patients in the emergency room, to planned interventions and as an outpatient. And you know, that doesn't always work that way. For the last 15 years in Dallas, I've always had one of the members of the vascular team in clinic with me a half a day a week. So we would see about 25 people. Many of them would be post-op patients, but it gave me a direct conduit to have someone be seen in less than in a week usually, and an opportunity to see the same patients with the person that did their vascular intervention. So I think it really expedited care, and it gave us some comfort discharging people early because we knew that we were the transition. So I'm really going to focus on American models because it's different in Europe, but I mean, this is the end of the story. There's a reduction in utilization, so if you can get a health insurer to buy into this, all the stuff that makes them happy, there's a dramatic reduction. There's a dramatic reduction in emergency room utilization, hospital admissions, length of stay, skilled nursing facility utilization, and then the things that we love, there's a reduction in all amputations, and usually a big shift from major amputations to minor amputations. When you then shift those people for preventive care, there's a dramatic reduction in re-ulceration, and then all of the things that entails, so the dominoes just don't continue to fall. And again, the idea is really to shift care from the hospital to the clinic. So these are American studies. This is not any new data. These are actually kind of old studies. There's a growing body of evidence that's published in the vascular surgery literature that has similar results. I'm going to share two programs that I work with. One at a large county hospital in Dallas, and then the other from this disease management model that we did in San Antonio. So, do you need a diverse team or not? I mean, for me, always the most important handoff or first person on my cell phone is my vascular partner. You know, I usually check to see who is the ID guy on call before I make a consult. I usually get in trouble because the vascular person I use may not be on call, and I call him anyway. And then all the other things, wound care, endocrinology, rehab, those kind of fall later down on the list, and they shift more to the outpatient side often. So this is another cartoon that kind of shows this. In the model that I've been involved in, we've kind of been the gatekeeper. My wound clinic is really busy, so I see probably 100 people a week in wound care. 25 of those are with the vascular surgeon that I interact with. So we really have tried to shift from the ED, although we still get 5 or 10 people a week that come in through the ED. Most of those are people from our clinic now, and it's a very collegial back and forth with vascular. As it shifts to the outpatient, then it becomes more, having the time to send people back for clinical labs and physical therapy and preventive services. So the disease management model is really screening people that are high risk stratifying, providing prevention care, providing evidence-based wound care for people when they have wounds, refer them early for revascularization, and unfortunately, repeat. So it's a patient population that has a high recidivism, and you're gonna see them often. So this is from this disease management program. I think this was from the Humana. We had 20,000 lives, 2,700 people that had diabetes, 74 were Medicare. And so this is what I like. So this was a well-established program. I don't know what they had, 300 or 100 internists. So we reduced the lower extremity amputations by 52%. So, but what the insurance company liked was we reduced overall hospital admissions for lower extremity problems by 38% and reduced their skilled nursing facility admissions to 70%. So people went home more on a PICC line. We saw them back in clinic, so they didn't go to the skilled nursing facility and wait and wait and wait. So these are days 1,000 for lower extremity disease. You're not gonna find these in the literature because no one else picks this apart like that. We had a 20% reduction in the length of stay. The length of stay was 5 days when we started. And then we had a 37% reduction in the skilled nursing facility length of stay. So if you look at how all this played out, it was a 65% reduction in the total days per 1,000 people, which translated to a chunk of money. So this is data from Parkland Hospital. So Parkland Hospital was a big county hospital. I started a program there in 2010. Before that, if you went into the emergency room, you saw general surgery. So this is the foot-sparing procedures, and I started with me and a PA in a 1,000-bed county hospital. So if you look at the foot-sparing procedures, it was about 40% of the patients when general surgery kind of ran the service, and it inched up to 65, 70% in 2017. And this is kind of how our program grew. I started in 2010 with a PA. We added another faculty person in 2012. We added fellows in 2013. We had an extra person to cover call. We got extended OR time, so essentially we were able to operate every day. And then we were able to grow our clinic, so we essentially have like 20 half days of clinic now. But this is a model where they want you to bleed before they put any compression on your wound. So we really had to suffer before they would give us another person, another access to clinic, which I think is the county hospital way. And during COVID, our amputations and revascularizations really didn't change. One of the things I was able to convince administration was, someone comes in, let us take care of them, because what you want is more beds faster. And so they agreed to that. So really, we still had about the same proportion of amputations in that time period. Our numbers didn't go up. So this is a paper for J.R. Chong. He was a brand new minted, fellowship minted vascular surgeon. He's now in Joe Mills' group at Baylor College of Medicine. So this is data from this program at the county hospital. So this is people that presented. 85% of them had ischemic tissue loss when they presented. 8% immediately had a major amputation. 68% underwent revascularization. So we looked at people that were involved in a multidisciplinary team and people that got standard wound care, and their amputation-free survival was longer in the group that had multidisciplinary team. This is the survival analysis for that. So you can see the multidisciplinary team is up here, and this is kind of the standard of care wound clinic. And when we looked at a regression analysis, I think the things came out that you would think. People who were non-ambulatory, and probably those are the people that didn't get revascularized. So people that weren't revascularized and people that went and got standard wound care were the ones that were more likely to have our proximal amputation. So there's a lot of opportunities for intervention, as I said, as you move across this and then back again. I think really it involves treatment and prevention, so a lot of that you don't have to deal with, but it gives you a handoff when you pick the right person, that it's going to provide evidence-based care, have a higher healing rate. The person's going to focus on complications and identify them early. I mean, the thing that still breaks my heart is a really great revascularization and someone gets a pressure ulcer and they lose their leg 3 months later because they have osteomyelitis or they're healed. I think that person that is attuned to this patient population provides fast referral and better communication. The thing I hate the most in electronic medical records is messaging. I still would rather pick up the phone and call the people that I interact with. Someone's going to aggressively debride wounds, provide offloading, use negative pressure wound therapy, et cetera, and be the person with you that can transition from the hospital to the clinic. And then they can do a whole bunch of preventive things that, that will reduce reulceration by 50% with very basic interventions. So thank you, I appreciate your attention.